Oh, there you go.
Okay, I think we're live. I would like to welcome everyone to our second PBC Facebook Live event of 2021. My name is Gail Wright, and I'm president of the Canadian PBC Society, a support group for PBC patients and their families. Our group is a registered charity completely run by volunteers, many of whom have PBC like me. I'd like to thank all of you who have made donations that support all of our programs throughout the year. And I'd like to recognize our series sponsors, Intercept Pharmaceuticals and CymaBay Therapeutics. Tonight's topic is understanding and managing PBC fatigue. And I'm pleased to introduce Dr. Mark Swain, who will be a presenter and our moderator. Many of you already know Dr. Swain, who is head of gastroenterology and hepatology at the University of Calgary, where he holds the Cal Wenzel Family Foundation Chair in Hepatology. His accomplishments are too many to list. So for tonight's program, we're honored to say that Dr. Swain is internationally recognized leader in PBC research with a focus on PBC fatigue. Welcome, Mark, and I'll hand it over to you now.
Thanks so much, Gail. It's great to be here. I'm just going to start off here by giving a bit of an introduction about fatigue, and then I'm going to pass things off to our two distinguished guests tonight, who are going to enlighten us about other causes of fatigue, and then about what some ways that we can approach fatigue with regards to exercise. So first of all, with regards to fatigue, I think as anyone with PBC will tell you, there's a spectrum of symptoms, and everyone experiences PBC in their own way, and some people have no symptoms, and some people have profound symptoms. But fatigue is one that really stands out, and it's a symptom that is the most common symptom in PBC. So when you're looking at fatigue in PBC patients, as I mentioned, it's the most common symptom, and in some patients they feel fine, they don't have fatigue at all, and some people it can be severe and actually incapacitating. They really have trouble living their normal life because of it. Typically, women with PBC have higher fatigue scores than men. It's not correlated with disease severity, and that higher fatigue scores are seen with longer disease duration, and higher fatigue scores are seen for PBC patients who are younger, who often have more severe disease as well. There's controversy about if it's whether or not it's improved by liver transplantation, because of course liver transplantation has a number of other issues that go along with it post-transplant, but in general it's felt that it's not significantly improved by liver transplantation, and for sure it's poorly understood. So the first question I often get asked when I see people in the clinic is, well, I'm going to start this therapy, is this going to help my fatigue? And so the question is, do the currently approved therapies actually improve fatigue? And this is one study. There's many studies, including the original studies. But actually, this one looked at all the different symptoms that I listed on the first thing. And here's fatigue here. And you can see the people that respond or don't respond to our urso therapy doesn't change fatigue. So there's no impact on fatigue with regards to urso therapy. What about the newer kid on the block, obeticholic acid, or OCA? Again, if you look at this, essentially the key study that was published, that fatigue is not improved in these individuals who get OCA broadly. And again, everyone's different, right? And one thing you commonly hear about people that have PBC is that and this is I think common across the board, it doesn't matter which experience or disease of individuals might have, is that physicians often focus on the objective measures of a disease. And so with liver disease, it might be the FibroScan, or it might be the blood tests. And physicians are typically, not the ones here tonight, but are typically less comfortable with symptoms that are more subjective in nature. And so fatigue is subjective, right? Because it's how you feel. So often when people have fatigue, it really highlights to those individuals their experience with the concepts of subjective wellness, which is, do I feel well? And objective wellness, when your tests might have normalized on ursotherapy, and then so the patient hears, well, your tests are normal, so you are well, despite the fact that they might say, I don't feel well. And so I spent a lot of time looking at how in the setting of liver disease, so PBC, why people don't feel well, and so the symptoms like fatigue, because of course there has to be a change in the brain to experience a feeling. And so that feeling is fatigue, which we're going to talk about tonight. And so I spent quite a bit of time, and I've talked before about this, about how do you look inside the brain to see why people with PBC might be experiencing a fatigue. And I've spent a lot of time looking in models of PBC, but also in patients with PBC. And so to do this, we use an MRI machine, which is just like, if anyone's ever had an MRI, this is exactly what any MRI machine looks like. So you can use any MRI machine, but you can pull out different information out of it than just looking at the structure of the brain. And so we pull out other information that tells us other stuff about how the brain is working. And in fact, what we're quite interested in is about the neural circuitry. And so the best way to think about it is that this is really about electrical wiring. So it's essentially neurons in your brain are just like electric circuits in your house. And that is, when you have what happens is these electrical circuits, they interconnect all through your brain. And it's really how the brain talks to itself to keep us feeling normal. So if the electrical circuitry in your house isn't working very well, then the lights don't go on. Similar thing here. If it's not working right, then you're not going to feel normal. And so the question that we've been very interested in asking is, does PBC change the brain's electrical wiring? I'm just going to show you one picture, and in fact it does. And it globally changes the wiring, but if you look at people with PBC who have fatigue versus those that don't have fatigue, the wiring is different. So what this shows, it doesn't really matter. This is just a brain with some colors superimposed, but essentially what it shows is these parts of the brain are in patients that have fatigue connect differently to other parts of the brain compared to those that don't have fatigue. So there's something about having fatigue in PBC that changes how the brain's neural circuits or their electrical circuits are talking to each other. So there's definitely a change in the brain that drives fatigue. And so I think it's really important when we're talking about fatigue that we recognize that there's subjective and objective wellness. And what we're looking for here is in the end, for someone with PBC to say that I am well. So they feel well, and their objective measures, maybe their liver tests or whatever, are also normal. We're going to hear today tonight about ways that we can work on this global feeling of I feel well. So I want to turn now to our second speaker, who is Magnus McLeod. I think everyone knows Magnus. He's a leader in PBC work, and he really is interested in the symptoms as they relate to PBC as well. He's going to talk to us tonight about other things that can cause fatigue. Take it away, Magnus.
Thank you, Mark. I'm just going to share my screen and I want to thank everyone for the invitation. So my name is Magnus McLeod. I'm over here in Halifax, Nova Scotia, and I don't know how many people are watching, but I'm going to mainly talk about fatigue. I've listed here many of the non-hepatic symptoms of PBC here, and they all have some things in common. Mark talked about the subjective wellness, and here I kind of talk about it as poor quality of life, but in general they all cause a poor quality of life, and they don't really correlate with how your liver's doing. And as we heard, not only the fatigue, but all these symptoms can worsen despite PBC treatment. We've heard a lot about fatigue, and I'm not going to go into this, but it is one of the most common symptoms in patients with PBC, and I'm glad we're doing discussion about fatigue, it tends to get neglected since we don't have many treatments and we don't have much to offer, but it's something that really affects all of my patients and all the patients with PBC. So I'm going to kind of walk through my thinking as I see my patients and I talk to them about fatigue. And it's very important to know that, you know, with our PBC patients, they live this and they tend to almost forget what wellness is. And so with fatigue, it is important to mention to your physicians and to your specialists that, you know, you do have fatigue, because there are other things that cause it. And it's quite easy for us as physicians, and it could be easy for patients to say, well, my fatigue is due to the PBC. But as you'll see, there's a number of different things that can be looked at and assessed and possibly treated to make you feel better. So the first thing I think of is the fatigue, is it acute or is it chronic? And there's no real time points for that. But if a patient says, well, I started feeling fatigued a month ago, that's acute. When there's a time period where you know it started, that's always atypical. And I'll go through that. And then I also ask, you know, if it is chronic fatigue, is this more sleepiness or is this fatigue? And there is a difference. And then once I determine a patient actually has fatigue, is this a hepatic cause of fatigue or a liver cause, or is this a non-liver cause of fatigue? And I'm always thinking in the back of my mind, could there be a cancer in the background, because those can present with fatigue. So when I talk about acute fatigue, this is always something that needs to be worked up. If I have someone who comes into my clinic who says, I've been fatigued for the last couple of weeks, I can't move, I can't get up, and that's something that needs to be worked up. It could be an infection, it could be a new medication, it could be a substance such as a drug or an illicit substance, or it could be a heart, kidney, or lung disease that could be causing this fatigue to come on. And now we're living in the COVID times, and so it's always important to know that COVID can present with significant acute fatigue as well. So I'm going to focus this presentation mainly on chronic fatigue, meaning that the fatigue has plagued our patient for usually months to years. And when fatigue happens like this, I always start off my questioning whether to find out if they have more excessive sleepiness or is this really fatigue. It's a different symptom. And I kind of question my patients with something like this. Ever since you've felt fatigued, if given a chance, would you be able to sleep or nap during the day? And most of the time, patients, even though they're fatigued, can't really sleep. They're not tired to the point where they have sleepiness. But if there is sleepiness or excessive daytime sleepiness, I always think of a number of things, such as obstructive sleep apnea, central sleep apnea. And then I usually go into almost like a sleep history and try to find out if there's insomnia, is there restless leg syndrome? There could be periodic limb movements at nighttime, keeping them awake, but they may not even know it. Sometimes narcolepsy creeps up. It has been linked to autoimmune conditions such as PBC. And then there's always hepatic encephalopathy or confusion associated with cirrhosis of the liver. And then there's medications. And so many of these things can be assessed with during a sleep lab, and patients can be looked at that way. Once I've determined that it's not excessive daytime sleepiness, and this is a chronic fatigue type state, I then consider, is there hepatic causes of this fatigue? And so many patients who have PBC do have advanced liver fibrosis or cirrhosis of the liver. And when cirrhosis does develop, fatigue can be a presentation of hepatic encephalopathy or that confusion associated with cirrhosis. Patients can develop heart dysfunction from their cirrhosis, which can lead to significant fatigue because of the impaired blood flow from the heart itself. And cirrhosis can mess up the hormones within the body, which can cause adrenal dysfunction, and this can lead to significant fatigue. And then there could be other concomitant liver diseases that could be associated with fatigue, such as alcohol use and alcohol-related liver disease. There could be viral hepatitis. There could be overlap syndromes, other autoimmune liver conditions that could develop during the course of PBC, such as autoimmune hepatitis. And then patients can develop fatty liver disease. It's the most common cause of liver disease, and patients with PBC aren't immune to it. And then there's the very rare primary sclerosing cholangitis variant that can happen with PBC as well. And then I do consider the non-liver causes of fatigue. And these are very common in patients who don't have liver disease, but some of these things are quite common in patients who have primary biliary cholangitis because of their association with autoimmune conditions. Depression, as we saw in Mark's talk, can be a manifestation of PBC. And depression in and itself can lead to fatigue as one of its manifestations. And so I have here the PHQ-2 screening tool, which is just kind of a screening questionnaire. Thyroid disease is the most common autoimmune condition associated with PBC, and it's very easy to diagnose, very easy to treat. And sometimes it's the one thing we don't think of as physicians because we usually check it when we don't need to, and we always forget to check it when we do need to. Celiac disease is another autoimmune condition that can be associated with PBC and can go unchecked and can lead to significant fatigue. Vitamin D deficiency, it's very common in many of my patients, and I check the blood work quite regularly to make sure that vitamin D deficiency isn't contributing to the patient's fatigue. Anemia can be common for a number of reasons, but iron deficiency anemia is something, and there are blood tests to check for this. Pernicious anemia it's an autoimmune condition that can be associated with autoimmune diseases like PBC. And this is where you don't absorb vitamin B12 because of autoimmune attack of the cells in the stomach. And then Addison's disease, another autoimmune condition where you have an autoimmune attack of your adrenal glands, can be associated with it and can cause fatigue. And then there's rheumatologic conditions. Many patients with PBC have these. And in brackets, I have all the different blood tests, objective measures that we can look for in patients with fatigue that can help us diagnose these things. And then on the right-hand side of my slide here, it's very important to know what medications that you're on and what medications, as a physician, we need to know the medications you're on, because these can increase fatigue. Alcohol, a very commonly used substance, can increase fatigue. Cannabis, now legalized in Canada, can contribute to fatigue. And obeticholic acid, we saw that it doesn't help fatigue, but sometimes it's been associated with fatigue, and it's good to know that when you take it. Diphenhydramine, dextromethorphan, loperamide, beta blockers, all have been associated with worsening fatigue. So this is a kind of a summary of my approach, what I've already gone through, but in someone who presents with chronic fatigue, I do determine if there's excessive daytime sleepiness. If there is, I send them for a sleep study. And then if the fatigue isn't related to sleep, or even if it is, I do go through the tests. So if there's hepatic causes, I usually screen out those with liver tests. I usually ask myself, could there be cirrhosis of the liver or not? I do a FibroScan or imaging. And viral hepatitis, if patients aren't immune, they've gone traveling, they can get viral hepatitis. And there's easy tests to look for that. Fatty liver disease, probably the most common complaint I get from patients with fatty liver disease is fatigue as well, interestingly. And so I usually do some sort of imaging to decide if they have concomitant fatty liver disease as well. Depression, I always screen for that in every patient. And I always take a medication and substance use history as well. And my initial workup usually includes a CBC to look for anemia, ferritin to look for iron deficiency anemia, a CRP to look for inflammation associated with possible rheumatologic conditions, vitamin B12 level, and a vitamin D level. And usually this picks up most of the secondary causes. And if this is all negative, I think of more rare causes like Addison's disease, like I mentioned before. There's a few pearls I like to think of when I treat depression in patients with fatigue. Bupropion, otherwise known as Wellbutrin, is an antidepressant that I like for a couple of reasons. One, it doesn't cause drowsiness, and it has been associated with possibly improving fatigue in patients with PBC. It's also associated with weight loss if patients are overweight, which can be associated with fatty liver. And then also smoking is never good for many reasons, and it has been associated with helping smoking cessation. Sertraline is a medication that is used in patients with PBC to help relieve itching. It is important to know that sertraline is not associated with weight loss, and it can be associated with weight gain, but it also can be associated with insomnia. And so it could worsen fatigue in that respect. Mirtazapine is a medication that's used more and more commonly in patients with PBC. It can be associated with weight gain. It doesn't usually, it can worsen drowsiness, so it can actually worsen fatigue in some patients, but there is the possibility that it improves outcomes in patients with PBC as well. And one of the last points I wanted to make, if at any point a patient comes to me and has any of the symptoms such as chronic fever, drenching night sweats, or unintentional weight loss, I worry about cancer. And there's certain tip-offs that make me think of specific cancers over others. If a patient has a family history of breast cancer, I worry about that and assess for that. If there's a family history of colon cancer, if there's a personal history of inflammatory bowel disease or primary sclerosing cholangitis, or if there's bowel changes or blood in the bowel movements, I always question about colon cancer. If a patient has a history of smoking or it has a cough, especially if it's a bloody cough, I worry about lung cancer. And if a patient has advanced liver disease or cirrhosis, I worry about liver cancer. And it's important for not only patients with PBC, but all patients to make sure that they get their preventative cancer screening tests done. Mammograms to surveil for breast cancer. We have the FIT test here in Nova Scotia to screen for colorectal cancer, and the PAP test for cervical cancer when it's indicated. So that's my mind frame when I assess someone for fatigue. And this is what I'm thinking of in most of my patients with PBC. I screen for many of these things during my Q6 to 12-month visits. And you do pick up some here or there. And I don't always assume the fatigue is related to PBC.
Thank you, Magnus. That was great. So our next, we're going to do all the questions at the end, but our next speaker, we're very fortunate actually tonight to have Andre Duarte here. He's from the University of Pittsburgh, and he's really a leader and pioneer in exercise physiology, essentially, as it relates to advanced liver disease, and really exploring something that we probably don't do enough of, and that is making sure that our patients with who have liver disease actually try to use as much exercise as they can to employ it, not only to help their objective wellness, but also to help their subjective wellness. And he's actually got an app that he's going to talk about. It's called LFit, and he's going to talk about that. I talk about fitness and the importance of that, and really how that might be something we could use to also address fatigue. So great to have you here, Andre.
Thank you, Mark. Thanks for the introduction, and thank you, Gail, for this invitation. So what I will introduce to you is a new app that actually we pretty much just launched it last month or maybe at some point in December. And the first patients that have been added to the app, we truly started with one patient in December, and everybody else has been added more recently. And I'm going to show you some of these, how it works. And I think this is something that we can use for fatigue, because exercise is really the way that we can better battle the horrible fatigue that, as Magnus just mentioned, is so difficult to really understand what is the underlying cause. Once we have ruled out everything else, once we know it is really attributed to cirrhosis, that one of the very few things in the lack of any pharmacologic therapy is just lifestyle intervention, lifestyle modification. So LFit is something that can help us to accomplish that goal. So the problem that we have with advanced liver disease, again, is as the liver goes from healthy to cirrhosis, this is for any type of liver disease, fatigue is really a key problem in there. And in patients that, particularly in patients that are waiting for liver transplantation, there's going to be a muscle loss that is very, very significant. You can see here in red, this is a patient that has lost a lot of muscle. This is a patient that has a normal muscle. And there is also problems with frailty, where patients are not strong enough to do their activities of daily living, to be independent, to be autonomous. And that causes problems both to the patients and to the caregiver. So sarcopenia and frailty are really important for the quality of life of our patients. And that is pretty much what I have a research lab on sarcopenia and frailty. And what we have found is that is truly exercise the way to improve these two circumstances. There might be some other interventions, you know, diabetes needs to be well controlled, the PBC needs to be under control, viral hepatitis, whatever that needs to be done medically is going to be important, but exercise is really going to be key. And we recently published the recommendations from the American Society of Transplantation. Sorry if I am biased towards transplantation, because that's what I do mostly. I do general hepatology, but I do a lot of transplant hepatology. So in these guidelines, what we are recommending is that we need to assess for this frailty or for this debility in our patients in a very objective way, not only the fatigue, but the actual effect of the fatigue, which is the loss of functionality. And we need to be sure that our patients are able to get a prescription for exercise, get a way to exercise. So if the patient has a normal function, they just need to follow the recommendations that are out there for the general community. So everybody should be exercising 150 minutes of moderate to at least moderate intensity of exercise. And we're talking that this should be at least in three to 5 sessions per week. So if you decide to do, 3 sessions of 50 minutes, that is perfect. If you decide to do more than that, 5 sessions of 30 minutes, that is perfect. And of course, sometimes patients are so fatigued that they cannot do that. But then what we recommended is, okay, just do 10 minutes here, 10 minutes at noon, and then another 10 minutes in the afternoon. So of course, for the patients that are having some form of frailty, some form of debility, there might need to be a very specific prescriptions for them. And this is what I'm trying to point out here. Now, the problem is that, when our patients go to the doctor, and this is really most of the doctors, including myself, we don't know how to do an exercise prescription. So we tell our patient, hey, you need to exercise, and you need to do this or that, but we really don't have a good way of telling this is specifically what I want you to do. And when we refer them to physical therapies, or when we refer our patients to go out and look in the community to somebody that can give you an exercise prescription, many of those providers might actually not feel comfortable doing a prescription for a patient that has liver disease, especially if the liver disease is advanced, and especially in transplant candidates. But again, this can apply to pretty much anybody that has liver disease. So we came up with the idea of just putting everything together, standardize the intervention, and create an algorithm that through an app, you can actually do the exercise prescription, and that the app will provide you with a type of exercise that it is okay for you to do and that is going to be healthy. So this is called LFIT, Exercise and Liver Fitness. This is still in press in liver transplantation. We have a website, which I will invite you to go and check. And if we have time, I'm going to show you a little bit of that. So the way it works is that the prescription, the exercise prescription is already embedded in LFIT. So the patient downloads the app, it works for Apple, it works for Android, and pretty much what you need is gonna be there. There are 3 different intensities for exercise, because irrespective of, especially for some patients that are more in their 50s or 60s, especially for those patients that they might remember how when they were 15 or 25, they were able to lift 50 pounds or 100 pounds. once with the process of aging, with the process of sarcopenia, with the process of liver disease, we no longer can do that. So we have to start a little bit lower, and we have actually to start low and go slow. And so the idea is that the algorithm will actually provide the patient with either the most basic form of exercise, which we call strength and mobility. These exercises are for patients that are really, that are truly debilitated, that are frail. They start exercising in a chair. We have a low intensity training, which is videos for patients to exercise, which, you know, they're ambulatory and they don't have to be exercise. They have to be stick to a chair to do the exercises. And there is a moderate intensity training, which is pretty much what anybody in the community should be able to do. And the idea is that there is a progression even for each of these categories. So if a patient gets assigned to strength and mobility, you know, that patient can start with video one. Oh, video one was too easy. Okay, I'm gonna do video two. You know, it's gonna be a little bit more demanding. Oh, that was still easy. Okay, video three. And so you can go and graduate from all the videos from strength and mobility and then change to the next intensity and so forth. And again, the idea is that this will be especially for the frail. These for patients that are have some form of debility, but it's not what we will call frail. And the third, the moderate intensity for patients that are robust. So these are some of the shot screens that we have. And so we have, the app is actually very simple. We wanted to keep very simple so anybody can use it. So there is no health literacy issues or technology literacy, severe technology literacy issues. So it's only sorry about that. It's only 5 screens. I'm looking for my cursor. Here it is. And so the first one is just the videos. And we have 4 educational videos that educate both the patient and even the provider. This can be watched by providers. And we'll educate the patient on how to exercise, what's the benefit of exercising, what is it that we're trying to accomplish, what are the consequences of having frailty or having sarcopenia, or what I mentioned before, this muscle mass loss. And there is a 4th video, which is the one here from Margaret Polly, which actually tell the patient how is it that they should be eating to prevent muscle mass. So here I'm showing a few of the videos for strength and mobility. The patient will just click in the video, click in there, and the video will open. Low intensity, coordination and balance. So the coordination and balance is an extra set of exercises that are only available for those that were allocated to low intensity or moderate intensity. And it includes like some back stretching exercises. It includes a Tai Chi class. And the whole idea of now that we have this platform, the whole idea is that we can continue adding more videos and adding more things now that this is available. And so we can really cover a broader group of patients, but with every single need that they might have. This is the second screen that we have, where, you know, Magnus was just telling us how important is sleep. And indeed, you know, if a patient doesn't sleep well, that patient is not going to do well for the rest of the day, and he's not going to be able to exercise. So after we link a physical activity tracker, and we can link this Elfit either to Fitbit or to Apple Watch, after we link them, we can actually monitor how much the patient is sleeping. We can see, for example, here in percentages for the day that we are evaluating. And then we can see also the intensity of the activity, because it's not only about whether you should be doing low intensity exercise, moderate intensity exercise, but whatever you do, you should be doing with certain intensity of training so that your heart beats faster, so that it really creates a challenge for you, because otherwise your heart and your lungs and your joints and your muscles are not going to really give you the benefit that an exercise is supposed to give you. So here, if you just like hover the cursor on your app, you can see the steps that you're doing. Here we assign a goal. So for example, this is a goal that I set for me at 10,000 steps per day. But, you know, for a patient that is debilitated, or for a patient that has severe fatigue, we can start with this goal only at 2,000 steps per day, for example, or 3,000 steps per day. And then we give badges depending on what is it that the patients are accomplishing. And this is just so there is like a positive positive reinforcements, just a motivation for the patient to continue doing what they're expected to be doing in terms of exercise. And of course, we monitor, or we are able to record and capture how many videos the patient is watching and exercising with. And of course, there is a leaderboard, and in this leaderboard, these that say LFIT 05, 02, 07, 09, etc. Those are true patients, and I am trainer 1. Trainer 2 is actually Dr. Don, who is 74 or 73 years old, and you know, you can see how he was beating all of us. So this is not about age. This is about lifestyle modification. This is about just setting your mind to do the right thing and to do the things that you're expected to do to become more functional, which in turn will help with your fatigue. So the fourth screen that we have, this is where people can actually see what other members of the community are doing. You can cheer for patients. You can send a thumbs up to a patient that is accomplishing something. And the last screen, this is where we can send patients a message. So for example, when there is a new member in the community, I will try to send them a message and say, hey, welcome for becoming a new member for LFIT, etc. So the whole idea is that for peers to recognize each other and for peers to understand that no matter whether they're sick or not, they can do it. And it is through this community, this exercising community, that patients can support each other and just improve their ability to function and their exercising capacity by working together this is actually a virtual exercise community. So what is it that I see on my side? So on my side, as the developer or as a trainer, I can see what's going on. I can see the members. These are all physicians, or there are no patients in here. And I can see also what exactly they are doing. So I can see the videos that the patients are watching, or that the participants, sorry, are watching. I can see the steps that they're accomplishing. And here, the darker the blue, the more intense the intensity of the activities that they are performing. So when we did this in the first 28 patients, and here I have results for 23, we actually could see that there was a pretty significant group of patients, and it was actually the patients that were the weakest in our group, in this group, that they did a very significant improvement in the numbers of steps. This is only 4 weeks of using the app. There are a couple of groups that really didn't change, but there was another group that just went down. And how much of this is affected by the diseases? How much of this is affected because they got into the hospital, because they got an infection, etc.? Well, it's important that we recognize that in future studies, but we know in this proof of concept study that just motivating patients virtually through this app, we can have them become more functional, we can have them be more mobile, and we can have them improve with the fatigue. Because as a matter of fact, one of the main things that patients will tell us was that their fatigue was improved, and they just felt pretty much the best that they have felt in a while after they had participated with us in these 4 weeks of exercise. So this is just to reflect that, you know, there are patients that are just self-motivated and patients that are just going to be hard to train for whatever that reason is. And those are the patients that we need to focus more as providers and as physicians. So a few of the improvements that we have for LFIT that I'm trying to create and eventually add to the app is that the patient can actually tell us how intense they are feeling the exercise. And this is just a standard scale that we use in training. And so that I can do through artificial intelligence, this is like some of the databases that we generate from capturing all of the data that is coming from the personal activity tracker or the physical activity tracker. And so the idea is that I can use artificial intelligence and I can actually identify what exactly patients are doing in each minute of their day, so that we can be very accurate in saying, hey, you're really getting your 30 minutes of exercise per day at a moderate intensity, or you know what, you're doing 60, etc. So we can really provide a feedback and make the patient like create their own, become autonomous in deciding what else is it that they need to do. This is a lot of this has to do with a game. It's a concept of gamification or motivation and creating autonomy and independence for the patient. And the other thing that we're trying to do now that we have a telemedicine is that we can actually assess remotely how our patients are doing. So I know that if I give a Fitbit to one of my patients and I have them use the LFit, I can recover all of their steps, and I can see that there is a relationship between their stride length and a few characteristics like sex. Height is also another one that I'm not showing here, but height was also significant. So height, the gender, this is a measure of how strong they are when we test them in the clinic. This is a measure of their coagulopathy. So with this, I can predict what is gonna be the stride that my patient has. And then remotely, I can do this test, which is a pretty common test that many transplant centers or many offices that take care of rehabilitating patients use, which is called a 6-minute walk test. I can actually do this test without the patient having to come to the clinic for me to watch the patient, how he or she is doing. I can do this remotely. And this is another of the benefits that we can do with this type of mobility that actually have been given by COVID and by having to, reinvent ourselves in how we do our clinics. And just to give you one of the patients that I showed to you, one of the first 28 patients or 23 in whom we had data from the tracker. Now we have 51 patients that have included in a clinical trials. And we have maybe about 8 or 9 patients that are just using LFit as standard of care. Gail is one of them, and I see her progress there. And I think she's already beating me, by the way. And but here I'm showing you one patient. This is how poorly he started when we got him into the program. He was doing 631 steps on the first week. That is, I mean, you really have to try hard to walk that little, but this is how sick he was. And this is how deconditioned he was. And eventually he even did worse. And as you know, we started like calling him and telling him to do this, telling him to do that, watch this video, do this, do that. This guy actually did pretty good. Eventually underwent transplantation. And prior to transplantation, we were able to improve their physical fitness or their functionality. This is using something called the liver frailty index, which I used before, something that is associated with the stride of the patient. And we can actually improve it by 0.6 units, which, just believe me, this is actually a huge change. And the patient did very well after liver transplantation. So now what we know now is that on top of what we've been recommending about the type of exercise, we now understand better that if we give our patients a monitor and we do all of this remotely just by walking, and it's actually, I have to say here that the person that taught me this was Jenny Heathcote when I worked with her in 2009. The first study that I did with a pedometer back then, with technology that was way, way inferior than the one we have, was at the Toronto Western Hospital, just teaching our patients to walk. Just by walking, we can do a great difference and a great impact in the fatigue for our patients. So this is, I'm just gonna leave this slide for a few moments. This is just to recognize some of the people that have collaborated with me in this project and some of the grant support that I have. Thank you.
Thanks so much. That's so interesting. I mean, the reason why I became a hepatologist was because of Jenny Heathcote, actually. So it's a small world, right? Jenny's touched a lot of people in the world when it comes to liver disease, and both patients and physicians. So we have time for an open sort of discussion. Please feel free to use the chat capacity on Zoom if you want to ask a question. I might just start off by asking a few questions myself, but if you have any questions, please put them in the chat room. Maybe I'll start off with Magnus here. And are there any side effects of fatigue? Any suggestions on managing those? These are from patients, actually.
Any side effects of fatigue? Was that the question?
Yeah. Are there any side effects of fatigue? Any suggestions on managing those?
Yeah, I would say it's hard to answer, like, what are the side effects of fatigue, but I would say one of the biggest side effects that I would see clinically would be almost like that vicious cycle mentality. When fatigue kind of gets going, patients may have a tendency to actually become, have a worse mood, or gain weight, or almost make the fatigue worse in a certain way. And it's important to know that fatigue is one of these things that it's important to go to your physician, either primary care specialist, to actually talk about it. And you're not alone in dealing with the fatigue. And it's good to kind of have almost like a plan. And we've heard a little bit about, even the exercise, but you almost have to have somebody on your side when you're dealing with fatigue, because if you don't deal with it, it will consistently get worse. And it's almost like the same with all the kind of symptoms that are tough to treat. You can get into this vicious cycle where it just kind of gets worse and worse and worse. And the fatigue will just get to the point where you're sitting in bed doing less than 350 steps a day. But I don't know if that's the answer you're looking for, but the side effects of fatigue would be like causing fatigue in and itself.
I think that's a great point about having a strategy with your caregiver on how to deal with your fatigue and how to move forward with it as opposed to backward. That's a great point. So here's a question in the chat box. So can a patient sign up for LFIT, or do they need their doctor to refer them?
Thank you for asking that question, Gail. So I want to show you why it needs to be prescribed by a doctor. So let me just share this again. And so this is, by the way, Pam Bloomer. This is our physical therapist. She's very experienced with patients with cirrhosis. So the thing is that all of these parameters that you see here, if there's been a fall, if there are these medications called beta blockers, if there is something called a TIPS that is used when patients have bled or have a lot of fluid in their belly, if there are medications for hepatic encephalopathy, what Magnus talked about, if there are diuretics, the hemoglobin, bilirubin, creatinine, the coagulation, all of those are used by the algorithm. So the app can say, yes, you're good for this degree, this level of training, or you're good for that level of training. So because of that, because the algorithm uses like some of your labs and some things that you might not know, like you might know that you're using a beta blocker, but maybe you don't. So it is important for a provider in the clinic just to do this prescription. So the way we're doing it, some of the prescriptions that we're doing are actually managed by a nurse or by a mid-level provider. And we're in our clinic, we have these forms that anybody can fill out. We believe this is very safe. We haven't had any complication. So it does need to be done by a doctor, but you can ask your doctor. You can ask your doctor to do that for you. And I can tell you that we have now patients we have a patient from France, one patient from Mayo Clinic. We have another patient from New York that they have asked their doctors. They get the information and they fill it out and sign it themselves.
So the doctor actually has to submit it on your behalf? Is that, and then it goes from there?
No. So what the doctor can do is just fill out that form, put what the hemoglobin is, etc. And actually a lot of those, it's funny because I think very soon any patient is going to be able to do it by himself or herself, because a lot of those measures, patients already have access to it, right? They already know in their app or their website what is their last hemoglobin or what is their creatinine. So a lot of those are actually filled out by the patients. And then they just call their office and say, hey, I'm trying to do this app to exercise. Can you tell me if I have had a TIPS? Have you tell me if I'm using a diuretic or a beta blocker? But it has to be done by the patient, not by the physician, because the patient has to sign a user agreement just like with any other app.
And it would be great to get people from all over the world to get an idea of differences from different geographical regions and sort of socioeconomic backgrounds, ethnic backgrounds, and it would be very interesting to see the differences, and then be able to temper the or change the exercise paradigms, maybe that to suit the different parts of the world or different cultures or whatever. Very cool. Yeah,
absolutely. And I think, you know, as you're saying, I think, for example, European countries, I mean, they walk a lot. So I'm sure that the cut of values for improvement in their physical performance might be higher than the ones we see here in the US and Canada.
Okay, so I'm going to ask Magnus a question. So is there any benefit or downside in pushing through the fatigue?
It's a tough question because it's an individual thing. Pushing through the fatigue, if you push too hard, the fatigue tends to come back with a vengeance. And so my usual strategy would be, if you're doing exercise or doing anything to kind of push with the fatigue, I would say take it, or almost like the mantra that Dr. Andre said was go, you know, start low, go slow. I can't remember if that's the words, but you kind of work your way, work your way to it. So if you're gonna, you know, you're taking stepping as an example, if you're walking or 2 and 500 steps, I wouldn't say try to get to 1,000 the first week you're doing it, but maybe go to 600 for the first week and then kind of work your way up, because you can go backwards. And the issue with that is whenever you fail your initial goal, it kind of takes you 2 steps back and it's harder to get going again. So in my mind, you know, start low, go slow.
Amen.
I love that. Yeah. So here's a question for you, Andre. Is activity the same as exercise? Is one better than the other for addressing fatigue?
So that's actually a great question that I'm not going to be able to answer, but let me tell you this. So it's not the same. That part I can answer. It's not the same. So exercise, it's a repetitive movement that you do to improve your fitness, right? And walking, if you're walking, for example, to just to improve your fitness, that exercise. But if you're walking as part of your daily activities, I walk to the supermarket, I walk, you know, with my children in the park, that is physical activity. That is not exercise. So there is a little bit of a conceptual difference in there. And I think everybody in physical training has understood the true benefit will come if you exercise, not if you do physical activity. But as more information is, or more evidence is being disclosed, it seems like physical activity, I'm not gonna dare to say is as good, but is equal, but it seems to be almost as good as exercising. So if you don't wanna go to the gym, but you know, you wanna walk a lot, and again, this is something that Jenny told me so many years ago, and it's ridiculous how after all these years trying to do more complicated exercising studies, just going back to the roots. You know, if you decide that what you like doing is listening to music and walk, then that's your stuff. If you only want to keep yourself busy, you know, park as far as you can from wherever you're going, go to the store walking, take the subway, etc. Yeah, that is going to count, and that is definitely going to improve your overall well-being.
Awesome, thanks. So next question for Magnus. In your practice, do you have many patients who still work full-time?
Yeah, I do have many PBC patients, and many of them are working full-time, but it's a little disheartening, because as you follow them over time, and you know, I've only been practicing for about 5 years now, but you see these patients who've gone from full-time work, and I'm filling out the forms to get you know, get them to go part-time, and they're having a lot of issues, and it is disheartening. But there are a number of patients who can't work full-time and who have had to quit their jobs because of PBC, and it's actually mostly the fatigue actually that causes them not to be able to work. I have many patients with cirrhosis of liver, their numbers are horrible, but when the fatigue sets in, that's really what makes it difficult to continue full-time work. They have very little, it's very hard to come back to work once you're done, once you've taken that time off.
Andre, do you want to, what about you? Do you want to touch on that one too? Or?
So I think it's very important to add objectivity to all of this. I agree with what Magnus said, but it's important to add objectivity. And I'm just going back to a little bit of the type of research that I do. This is why we use the personal activity trackers, because a lot of patients, I think fatigue, just like physical activity, just like your height and your weight, they're always gonna go through a very personal filter. Like I always weigh less, I'm always taller than whatever I'm actually on the scale or whatever I measure, right? I mean, that's everybody. You know, some people might be more objective than others, but the truth is that there are very personal biases. So I think fatigue is like that, and I think that, and going back to the question the questions that Gail was doing, it is important for you to go through it, go slow, and use some objective measure, because a lot of patients might say, you know what, I am very active. And it's not until they start tracking what they do that they say, oh yeah, I am actually not that active. So I think we have to give some objectivity. And as you even perhaps distract the mind to some other some other things that are more productive, some of that fatigue is going to disappear. I can tell you that so in the study, the first 28 patients that we did, every one of them had to go to like some end of study questionnaire, and they told us what they liked, what they didn't like, how we were going to improve the app, etc. It's all reported on the publication. And what was very obvious is that they really felt better. We only had 2 PBC patients, so we don't know exactly what happens with PBC, but we know PBC, for whichever reason we still don't understand, is more severe of this. And this is definitely like there is a need to do a study to see what exactly happens in PBC. And perhaps as we start adding objectivity to the physical activity and understand better how fatigue changes, because it doesn't matter if you feel you're very fatigued and somebody feels like it's less fatigued. Well, if in the end you see a change, I think by tracking that change more objectively, along with other measures of physical function, we might try to get to a better solution for our patients.
I think it was good. I remember when I got my first Fitbit, and I thought, oh, I'd do 10,000, no problem, every day for sure. I was shocked. I was a little short of 10,000, but so the objectivity. It can be quite. It makes you reflect. That's for sure. So, Magnus, how can a patient come out of a downward spiral of fatigue?
I think it's tough, but the best. I would say the best way is, the first thing, could this be like a non-PBC reason? And it is good to find out, to make sure that you don't have one of those things that I talked about. But the real spiral is you need almost like what Andres is stating here. You need almost like this type of measure that really puts you accountable. So I really like the idea of this app, and I've been sitting here thinking, well, this is kind of something that would like put a stop to a spiral. If you gave someone an app that literally told them what to do, and they had goals, and that could be a perfect answer to a spiral of fatigue. It monitors sleep. It tells you how many steps you're doing. I think it's a very good question, and with a very difficult answer, but maybe Andres is onto something here, because the app's a great idea, I think.
Yeah, I could just add it. I'm in Andre's group now, and it has helped. I wouldn't say I didn't have very much fatigue, so I can't really speak to that. But during COVID, during a pandemic, it's almost the same as being fatigued, because your life is quite disrupted, and your routines are all upside down, and your social life which goes with sort of fatigue and depression and isolation. If you can't, so it all, you might as well be fatigued, because if you can't see anybody, you are isolated, and you don't have as many things that you can do physically. So I was so really glad to go on the LFIT program, because it does give me that structure and those challenges every day. And, sometimes I get to like my goal is always 10,000 steps, but sometimes I get to 5,000, and I say to my husband at 8 o'clock at night, I think I'll just walk around the block, because I just want to get it so like I don't embarrass myself in front of Andres. I know he's checking on me. It's supposed to be anonymous, but he's looking at my stats. So I think, these challenges like help, when you're dealing with isolation, whether it's fatigue related or COVID related. So we can all relate to that, actually. I would highly recommend it, except for one thing I will mention is that the scoring on the prescription is quite different in Canada with the milliliters per liter. I don't know how you do it, but and so my MELD score was 30. That's very high because I filled it out with the wrong ratios. So make sure you're filling it out with the correct international units, or whatever they are.
Yes, thank you for saying that. I don't understand why, because Canada has done a fantastic job in joining the international unit system, but United States still resists. So yeah, we unfortunately use different units. So just keep that in mind when you enter your information.
Maybe are you planning on upgrading it? Maybe just get more international sort of people doing it, because most other countries, of course, are on international units.
Yeah, I will need to get the money for that, Mark, but I think it's a great idea.
We have time for a few more questions, Mark.
Sure. Okay, Andres, do you recommend weightlifting?
Yes. I think in the past we were really afraid about weightlifting because of varices, and if somebody has varices, this is going to be a hard thing to say, but there is not a single study showing in exercising cirrhosis showing that exercise increases the risk of bleeding. I think we all can remember a patient that said, oh, I was lifting this, I was lifting that, and then I started bleeding. So I think in our brain, we always think, and there is actually a study showing that when people exercise, the portal pressure, which is what can make them bleed, will go up. So there are a few nuances, but what we recommend is for everybody to start with 2 or 3 pounds, no more than 5 pounds. And I think, and I'm going to refer again to what Magnus said, if you overdo yourself, and you hurt your shoulder, you hurt whatever, it's just so difficult for that person to just start again and say, okay, I did it wrong, I have to do it again. So I think that we don't prohibit weightlifting to our patients. We just ask them to do 2, 3, never more than 5 pounds, go for repetitions, irrespective of the varices, irrespective of the risk for bleeding. In a few patients that we know have a high risk for bleeding, we might give them a medication to prevent that.
Wonderful. Okay, Gail, looks like we're going to wrap up now. Do you want to wrap up? That was really excellent. That was fantastic discussion, guys. Thanks so much.
That's what I was going to say. That was a great discussion, and I want to thank our presenters tonight. It was really informative. I learned a lot, as always, and I want to thank all 3 of you for everything that you do, not just tonight, but everything you do to support your PBC patients. We do really appreciate your dedication, and it's not just your clinical work, but your research work and your teaching work, because all of you are wearing many hats. So we do appreciate that. And I think one thing for tonight we can add is that sometimes the doctors are trying to lengthen your life, make sure you live a long life. But in this case, I think we're also trying to improve the quality of life. So that is much appreciated, and keep up the good work. And hopefully we'll see you at another session, because you're very popular, you guys. So thank you very much. And I'm going to sign off now.
Thanks so much. Thanks, everyone. Thanks, Gal.